We are really honored to have Luc Harousseau from France here, from the University of Nantes in France, to talk about transplant. He has been working in the area of high-dose therapy and stem cell transplant, bone marrow transplant, and myeloma for many years, and has been the author of key publications from the French group, the IFM, so that you have the IMF, and then you have the IFM, which is the French myeloma group, and he was the leader of that group for many years and pioneered their studies in the area of transplant. So please welcome Luc Harousseau to talk about the role of transplantation.
Thank you, Brian, for your kind introduction and for the invitation. As Brian said, the group, the French group, French Intergroup on Myeloma, has been very active for more than 30 years now, and I've published a number of very important studies. That's the reason why I would like the IMF put the IFM in the summary of acronyms of your booklets. You have all the groups, the Spanish, the German, the English, but not the French. Next time. Okay, so I understand that majority of you have already been treated, some for more than 10 years. So of course, I will speak of the initial treatment, which is too late for you. But I think it's important to know what is occurring in the indication of transplantation for frontline treatment of multiple myeloma patients. I think that there are three questions. The first one will be very rapid. I just want to remind you what is autologous transplantation. It was developed many years ago at a time where there was no other treatment than chemotherapy. So no improvement. And the only way to improve the results was to increase the dose, the concept of what we call dose intensity. But it was very toxic. That was the reason why researchers suggested to help the patient support high-dose therapy by adding stem cells from his own marrow, despite the fact that the marrow was infiltrated by plasma cells. So it was what we call autologous stem cell transplantation. And it turned out that high-dose therapy plus autologous transplantation was superior to conventional dose chemotherapy. It did improve the response rate and the duration of response. And after the first trial performed by my group, autologous transplantation became a standard of care, at least for younger and fit patients. Unfortunately, and we will discuss that, it couldn't yield cure. Almost all patients ultimately relapsed. So who is transplant eligible? We have discussed that in the previous sessions. I have to explain why there are differences between Europe and the United States. In Europe, most patients are treated within clinical trials in academic centers. And in clinical trials, especially the first one by the French IFM, there was an age limit to avoid selection of the best patient, the fittest and the patient without any comorbidities. So to avoid this selection bias and to avoid dropout of patients who could not tolerate the initial treatment, we decided to limit the inclusion to 65 years. That is the reason for this limit of 65. But in Europe, like in the United States, even a patient who is over the age of 65 can tolerate high-dose therapy if he is fit, without major comorbidities or organ dysfunction, and without no major renal failure. So the second question is, what is the best strategy, the best therapy, if the doctor and the patient have decided to go to upfront transplantation? You have to understand that after the introduction of novel agents, thalidomide, bortezomib, and lenalidomide, autologous transplantation is not a single treatment. It's part of a multi-step procedure with an induction treatment prior to autologous transplantation, and usually with novel agent, followed by hydrotherapy with high dose of IV melphalan, followed by what we call a consolidation, either with, again, new agent or a second course of autologous transplantation, which is still performed in some countries, including the United States. And finally, what we call the maintenance, which is mostly with lenalidomide. So I will describe these different types of the whole strategy. First, the induction therapy. What are the objectives, which drugs, and how long? The objective is to reduce the tumor burden prior to autologous transplantation, but also to clean the marrow, which is infiltrated by malignant cells, before graft collection. And by the way, we use blood. We have stopped using marrow because it's easier and it's more effective for reducing the duration of marrow toxicity. The condition is that it should be well tolerated, of course not toxic for marrow stem cells which are to be collected, and of course no severe complication before transplant. We want the patient to be fit at the time of transplant. How do we evaluate induction therapy? Mostly by efficacy criteria, and the most important criterion is complete response, which is disappearance of the monoclonal component in the electrophoresis, in the immunofixation, and which is also a normal bone marrow evaluation. We also use what we call VGPR, which is 90% reduction of the monoclonal component. So which drugs? We currently have 4 drugs. In yellow, chemotherapy, alkylating agent, which is mostly cyclophosphamide. In red, the proteasome inhibitor. The first in class is bortezomib, but we now have 3, bortezomib, carfilzomib, and ixazomib, which has been licensed both in the United States and in Europe. And in green, the so-called immunomodulator family. The first is thalidomide, second is lenalidomide, and the third is pomalidomide, but it is used only for relapsed patients. So the fourth one is dexamethasone, which is part of all combination. We now know that bortezomib or other proteasome inhibitor is necessary because it's more active in high-risk patients. We now know that triple combination are superior to double combination, and we have performed randomized trial showing, for instance, that Velcade, thalidomide, dexamethasone, VTD, is superior to thalidomide, dexamethasone, or to Velcade, dexamethasone. We also know that thalidomide is superior to cyclophosphamide, which is used in the VCD combination, or in the United States in the Cybordi combination. So the state of the art now is 3 drugs with dexamethasone, 1 proteasome inhibitor in red, and 1 immunomodulator in green. Which immunomodulator, thalidomide or lenalidomide? We don't have any randomized comparison of thalidomide versus lenalidomide in addition to Velcade. We have not compared VTD and VRD. But we now know that Revlimid is superior to thalidomide by a British study showing that CRD, cyclophosphamide RD, is superior to VTD. So the current standard are VTD in Europe, mostly for financial reasons, because thalidomide is cheaper than lenalidomide. VRD in Europe and the United States, and in the United States, Kyprolis is replacing Velcade. The future might be to add a 4th agent, and especially an anti-CD38 antibody, daratumumab, which has been approved in France, in Europe, and in the United States, and the next one, which is isatuximab. And these drugs are currently being introduced in the frontline setting. So we now have results that Rafat Abonou showed you regarding the introduction of daratumumab in addition to Revlimid dexamethasone in elderly patients. But we also have already quadruplet combination. For instance, Velcade, thalidomide, dexamethasone plus daratumumab. It's the study is called Cassiopeia and it's now finished. And it's sent for publication. And we have ongoing trial with VRD plus daratumumab. And these triplets or quadruplets with daratumumab do increase the CR rate and yield what we call negative MRD. So what is negative MRD? This picture shows an iceberg, and the part of the iceberg we see is the part of the disease we can detect with simple tests, electrophoresis, immunofixation, bone marrow aspiration. But you see that the majority of the disease is under the level of the sea. And it's from this part that the relapse comes. So we have to obtain deeper responses. And now we are able to attain the level of 10 to the minus 6, meaning that we are able to detect one cell out of 1 million. And if we cannot detect one cell out of 1 million, it's what we call MRD negativity, which is associated with a much better outcome. And on the left-hand side of the slide, you saw an IFM study which clearly demonstrates that patients with MRD negativity, in blue, have longer response rate or progression-free survival, as we say, than patients with MRD positivity. But what is very important is that the level by itself is important. If you detect 1 cells out of 10,000, it's not the same prognostic value as if you detect or don't detect 1 cell out of 1 million. So the best is the most sensitive. And currently with very sensitive techniques called next generation flow or next generation sequencing, we can achieve 10 to the minus 6. Finally, how many cycles? With VTD, we could only give 3 to 4 cycles because of toxicity, and especially neurologic toxicity. But VRD is better tolerated, so we can give 6 cycles and maybe more. So this slide compares our study, the IFM study, with 3 VRD, and the Spanish study with 6 VRD. And you see that the response rate, VGPR, is superior with 6, 68% compared to 3, 47%. Second, consolidation therapy. The objective are to increase the CR rate, to upgrade the level of complete response, and to achieve MRD negativity. These are short-term treatments, usually 2 or 3 courses of the same treatment used for the induction treatment, or in some countries, a second autologous transplantation. There have been 2 large randomized trials, one in the US, one in Europe, addressing the question of the role of consolidation with chemotherapy and the role of consolidation with double transplant. This is the US, and this is the European. I have to show you this. The induction in the European trial was only 3 courses of VCD, not optimal. All patients did receive maintenance, and I will discuss that in a moment. And the results are different. In the US study, no benefit of consolidation either by VRD or by second autologous transplantation. The curves are exactly the same. But in Europe, there is a small but significant benefit in favor of a consolidation. And for the second transplantation, it looks to be better in high-risk patients. How can we explain these differences? Well, just because the induction treatment was not the same. In the United States, they used VRD, which was the best, and for a long period of times. In the European trial, I told you it was a suboptimal induction with VCD. So if you have a good induction, maybe you don't need a post-autologous transplantation consolidation. or maybe you don't need a second autologous transplantation. I also have this comparison between the French and the Spanish trial. You see that with only 3 induction treatment, you can improve the response rate from the induction to post-consolidation to 69%. With 6 courses, you cannot improve the results with the consolidation. The results are the same, 79, 78, but because of the best induction treatment with in the Spanish trial, they don't need consolidation. Rapidly maintenance, the objective is prolonged remission duration by a long-term treatment. If possible, should be given orally because it's more convenient, and of course it should be well tolerated. Thalidomide is a good maintenance treatment, but it's too toxic. So currently the standard of care is lenalidomide, which has been approved both by FDA and EMA. And this is based on the result of 4 randomized trials, which showed, all 4 trials showed a very significant improvement, prolongation of the progression-free survival with lenalidomide maintenance. There are some questions. I've heard that some of you have received maintenance treatment for more than 5 or 7, 8 years. In France, we stopped the treatment after 2 years. Why? Not only because of side effects. Usually Revlimid is well tolerated, but mostly for cost reasons. Revlimid treatment is very expensive, so we cut the treatment after 2 years. And in some countries, Revlimid maintenance is not allowed. The other question are some concerns regarding the efficacy in high-risk cytogenetics. Lenalidomide should be less active in those patients. That's the reason why we are currently introducing newer agents, for instance, ixazomib, and we already have results, positive results, with ixazomib maintenance, and we are also testing daratumumab as maintenance. The conclusion, when the upfront treatment should contain transplantation, the standard strategy is 6 to 8 courses of VRD or VRD-like, like KRD, for instance, in the United States. You can give the 6 to 8 cycles either before transplant or before and after, for instance, 4 and 4 or 6 and 2. Then autologous transplantation, then Revlimid maintenance. But the key question for the future will be the impact of adding new agents like daratumumab. Third and last question, why opting for transplant upfront? The question is that we have now combinations which are very active and which can be prescribed for a long period of time since they are well tolerated. Dr. Dury pioneered the VRD and showed you the updated results, which are really excellent. KRD is probably the same, maybe even better. So we have very good results with new combination without transplantation. And we also know that we can delay transplantation at the time of first relapse. So this was a very important question which was addressed by 4 European groups, a randomized trial. These are 2 Italian trials, the French trial and the European trial. They all address the question, initial transplant versus no initial transplant, in addition to novel agent. These 2 trials showed a benefit not only in progression-free survival, but also in overall survival. This one, the French and the European, do not yet show differences in overall survival. But I would like to focus on the French trial, not only because I was at the origin of this trial, but also because the comparison was between autologous transplantation and the best non-intensive treatment. You see here, induction with RVD, autologous transplantation, consolidation with RVD, and maintenance. And here, 8 courses of RVD plus lenalidomide maintenance. So the best non-intensive treatment versus the best intensive treatment. What are the results? the results are the following: a significant and actually very important superiority of the intensive treatment in terms of progression-free survival. The RVD was good, 36 median progression-free survival, but the intensive treatment was even better, with a very good median progression-free survival of 50 months, so a benefit of 14 months. Unfortunately, until now, there is no difference in the overall survival. Maybe it can occur later, because the patients who have long progression-free survival, they will probably have long overall survival as well. But currently, there is no difference. And the major difference is the response rate. You see here, intensive treatment, RVD 5 courses plus autologous transplantation versus 8 courses. You see that the CR rate, complete response rate, is significantly better for the intensive treatment. The same for the final result, final VGPR rate. But maybe the most important is the percentage of patients achieving minimal residual disease. And here, it's at a low level of 10 to the minus 4 by the technique we call flow cytometry. 79% versus 65%, which is very different, very significant. But even more important, since I told you that the best level is the most sensitive level, 10 to the minus 6, you see that at this level, you cannot detect one cell after 1 million. 30% of patients achieve this type of minimal residual disease versus only 20% with non-intensive treatment. And this is very important, because this slide shows that if a patient achieves minimal residual disease at the level of 1 cell out of 1 million, the duration of remission, the progression-free survival, is very long. You see at 4 years, 75%, while if you have no MRD negativity, MRD positivity, the probability of being in remission at 4 years is less than 25%. So a striking difference. And this translates into a benefit in survival. For the first time, we showed that a patient who achieved minimal residual disease negativity has a longer survival. We have also shown that there is no difference between the type of treatment. If you achieve MRD negativity with non-intensive treatment, the prognosis is almost the same that if you achieve MRD negativity with intensive treatment, which is shown here, slightly better with autologous transplantation compared with no transplantation for the patient who are MRD negative. But the difference is that we achieve more MRD negativity with stem cell transplantation. So why opting for upfront transplantation? It's just because it induces more CR, more complete responses, and more importantly, more profound responses, patient achieving negative MRD. And these negative MRD are associated with longer responses. So if you consider that it's better to achieve MRD negativity, autologous transplantation can be considered as superior, especially in high-risk patients where, in my opinion, autologous transplantation remains necessary. So the conclusions are that frontline autologous transplantation remains the standard of care, at least in Europe, and is currently included in all ongoing trials. However, due to the excellent results of RVD or KRD for a long period of time, and the possibility of using autologous transplantation at the time of relapse, since overall survival currently is the same, delayed autologous transplantation is certainly a possible alternative, which is currently the discussion proposed to patients in the United States. I want to finish by showing you 2 slides about the next step. In my opinion, the next step is to achieve MRD negativity, which is becoming a new endpoint, at least in clinical trials. And I gave you an example from Dr. Jakubowiak here in the United States. he used 8 cycles of KRD plus autologous transplantation plus maintenance. But I wanted to focus on the results of these 8 cycles of KRD plus autologous transplantation. You see a very high proportion of patients achieving MRD negativity by standard method, and even 60% of patients achieving MRD negativity by sensitive method. But at the last ASH meeting, an Italian group compared 8 cycles of KRD plus autologous transplantation, by the way, 8 cycles of KCD plus transplantation, which was inferior, and 12 cycles of KRD without transplant. And you see here the results in terms of response. The response rate was the same comparing KRD plus 8 cycles plus autologous transplantation and 12 cycles without transplant in terms of response and in terms of MRD negativity. So 8 cycles of KRD plus autologous transplantation does not look superior to 12 cycles without transplant. Though my final slide is that prolonged treatment with newer triple combination, for instance, KRD or maybe DARA-RD, or even quadruple combination, will achieve very high CR rate and very high MRD negativity rate, quite comparable to what is currently achieved with autologous transplantation. So I think that while autologous transplantation will, in the near future, probably remain necessary in high-risk patients or in patients who don't achieve MRD negativity after induction, on the contrary, I don't think that autologous transplantation will be necessary in standard risk patients who achieve MRD negativity after good induction treatment. So when I started to work on multiple myeloma 30 years ago, I think that less than 50% lived more than 2 to 3 years. Now we have many patients having long progression-free survival, longer than 10 years, and we have patients surviving more than 20 years. So of course, it's a long way, but we are approaching. Thank you for your attention.
All right, so we can have time for, we have actually plenty of time for some open questions. Go ahead, please. What do we think about CAR T transplants?
T transplant, and will it cure multiple myeloma patients?
Okay, a couple of very simple questions there.
Question is CAR T? Yeah. Well, that's a very important question for the future. But currently, in the United States, and at least in Europe, CAR T cells are used only for relapsed patients. I think that the first group to test CAR T cells earlier in the disease is a Chinese group. They presented results at the ASH meeting using CAR T cells as a consolidation in high-risk patients. But I think in the future, and maybe starting with high-risk patients, we certainly could address the question of the role of CAR T cell. My personal opinion, and I would like to hear Brian and Rafat, is that we still have to learn efficacy and toxicity of CAR T cell in multiple myeloma before using them in frontline treatment.
Right. So for the CAR T, I think what we say, it's still the Model T. It's the Model T. We're waiting for the Maserati to come along. But there are many variations that are in trials right now. And as Jean-Luc mentions, in China, there is this one company, the Legend company, which is now working together with the Janssen company, and the trials with that product are now going on in the United States with that product. But there are many different new products of CAR T cells, and some of them are much safer and don't have this problem with the cytokine release syndrome, this CRS, which has caused some serious toxicity with the early trials, especially in patients with advanced disease where the patients are very sick. And so I have hopes that there will be new products which are equally or even more effective and have lesser toxicity. And then we would be comfortable to use them early in the disease, up front. And I do believe, I am optimistic that those could be dramatically effective. And we do work with a team in Shanghai in China where they're using one of those newer products, and they've already treated 50 patients with earlier disease. The trials move forward very quickly there. And so coming up in May, the first part of May, we will be getting the report on the first 50 patients that they've treated with one of those new CAR T products that's safer and seems to be working amazingly well. So I'm optimistic for the future.
Yeah, I mean, the science is fascinating, but the 3 S's, specific target, safety, and sustainability.
Yep.
So you want to make sure that you're attacking the right target so you can get rid of all the myeloma. You want to make sure it's safe, nobody end up in the ICU or in coma for a month. And you want to make sure that these cells last. You hate to see that, you know, in a year, these cells are gone and the myeloma is back, especially when you spend $2 million on that product.
Absolutely. Yeah, so the first product in the US, this one which is called BB2121, which is a Celgene Bluebird product, it's what's called not fully humanized, which means that you can give it, but because it's not fully humanized, you can't give like a top-up later. So you're mostly dependent on the impact from that first dose. And so now one of the new innovations is to use what are called fully humanized products, which means that you could give the initial dose and then you could give a top-up to maybe get some sustained benefit if you needed to. So a lot of potential for the future.
And maybe
right.
if Dr.
Yes.
Richardson arrives, he will discuss another way to target the same molecule on the plasma cells, which is not CAR T cells, but which is a very interesting type of antibody, which is called bispecifics, the BiTE antibodies, which
Right.
can have the same type of activity. So there are plenty of different possibilities in the near future.
Yeah, very good. Yeah, it'll be exciting to hear the updates on those bites. All right. So who's next? All right.
Is there any research underway or clinical trials underway using something that other than melphalan as a conditioning agent?
Oh, there have been. You want to comment? Yeah.
I couldn't hear the question.
Something other than melphalan for conditioning.
That's very surprising, but melphalan has been used for more than 35 years, and it remains the standard of care. High dose of 200 milligram per square meter, sometimes less in patients with kidney problems. We have tried to increase the dose, to add another drug, and it turned out that by changing this simple regimen, you add more toxicity without having more efficacy, or you have more efficacy but much more toxicity. So currently, melphalan remains the standard of care. The Spanish have tried to add another drug, which is called busulfan, and the initial results were encouraging, but I don't think that the randomized trial is positive. So currently,
Right.
I cannot say
Right. Yeah, that what's
More.
called the BUSI regimen, I think, is not more effective and actually has significant lung toxicity a little bit more. So, anyway, melphalan is good.
It is very good.
Okay, who's next?
I was in the B2121 trial, and unfortunately for me, it was a difficult trial, and the results didn't last very long. I mean, it
Okay.
was wonderful afterwards, but it didn't last for very long. So I'm on something different now. But I have a question about the technique that you're using now, where you're putting patients on the big guns, the daratumumab and the newer therapies at the beginning of their treatment, And unless I'm mistaken, what happens is that these treatments last for a while and then the myeloma becomes resistant to them.
Right.
So what comes next for these people? Because you're putting them on the big stuff right at the beginning rather than waiting until they
Right.
outrun some of the lesser stuff.
So I think a very good and important question. I don't know if you're starting to see this more, Rafat. Patients who, so this lady said that she went through the CAR T therapy, I think probably up in Hackensack, where they had the BB212 CAR T cell trial open, and then had a great response, but the remission lasted for how long?
A month and a half.
Oh, a month and a half. So a very good remission, but very short. And so then you're
That is
faced-
the question, yeah.
Yes. So what to do next?
Well, I've no experience, and I don't know whether it's possible to retreat with other treatment directed to the same target, for instance, the second course of CAR T cells. Or,
Yeah.
I don't know, but what
Yeah,
I can tell you, it's a more general problem, is how do we treat patients who are resistant to the treatment they have received? And we have started with patients who are resistant to bortezomib or to lenalidomide, and then we have looked at patients who are resistant to both bortezomib and lenalidomide, and now we are dealing with patients who are resistant to bortezomib, lenalidomide, and daratumumab.
Right.
So the question is how to treat those patients. First, we have new combination with the same drugs. And for instance, you can use pomalidomide plus daratumumab plus dexamethasone, which has some activity. Second, we have new agents.
Yeah.
Of course, it's difficult to develop rapidly because the patient need very rapid development. It's difficult to develop rapidly new drugs. For instance, there is one which is called selinexor, which can be active in patients who are refractory to all known agents, but which is a little bit toxic, and the
Right.
FDA is a little bit reluctant. So they have to find the good balance between efficacy and toxicity. We have venetoclax, we discussed that yesterday, which in combination with bortezomib can overcome resistance to bortezomib. So we have plenty of new possibilities.
Right.
You have
Right.
to
Yeah,
keep
so I think
hope. We have plenty
absolutely. We need to look at what you've had before, but some of these combinations can still work. And so I've used, for example, elotuzumab, pomalidomide, dex. I've used actually in one patient, but you could use some of these combinations, ixazomib, Brevdex, all these different combinations that we know can work, just to try them and see if you can get benefit in this situation. But it is challenging when you move some of those really major treatments up front. We don't really understand the best way to handle the disease that might be left.
I had a 6-course VRD induction. I'm in remission, and I'm being encouraged to have stem cell. I'm not rushing forward with that and would like to get my stem cells harvested and stored, and am told they're unwilling to do that unless I go through the whole process and get transplanted. How do you feel about just having your stem cells stored?
For later.
Are you a proponent? Yeah, for later.
All right, so if I'm understanding correctly, this lady is not keen to go ahead with a stem cell transplant, but is perfectly open to have her stem cells harvested and saved for later. So how do you feel about that?
As I said, it's another possibility. Again, in Europe, I think that specialists would recommend autologous transplantation up front because they do believe that their more profound response would be important for longer remission and maybe longer survival. But, as I said, there are other possibilities without transplant up front, and you can store the cells and use them at the time of relapse. I think it pretty much depends on the initial prognostic factors. If you have a standard risk multiple myeloma And if you have a good response to your induction treatment, probably you can continue without transplant and save the transplant for the time of relapse, if any. But if you have a high-risk multiple myeloma, or if you don't achieve minimal residual disease negativity, then I would strongly suggest to perform autologous transplantation upfront.
So Rafat, do you have a lot of patients who take this route to just go ahead and harvest the stem cells?
Yeah, I think the most important thing is the level of response. I mean, if you're in true remission, and yet, better yet, if you are MRD negative, then I would recommend harvesting and storing. With the caveat is that some centers now are, frowning on that because of the cost. They say, they can't charge the insurance company for maintaining these cells. But if you can get that covered, I think it's very important that we collect these stem cells early when you're in remission, because the longer you stay on certain drugs, maybe the harder to collect the stem cells, so.
Right. So one of the things that's going to come up for the future is for this CAR T cell process, what you need to do is harvest the T cells. And so obviously what would be really good would be to harvest those T cells early as possible, even if you were thinking to use them later. And so that's something that I think is going to come up moving forward, but that's going to be even more challenging to get reimbursement for that, to harvest the T cells to keep them for later. Okay.
Now I have two questions.
Uh-oh.
So, and I apologize if you already explained this, but what qualifies a person as high risk? That's my
Okay.
first question.
All right.
And then how long can you save or store stem cells regardless of insurance issues?
All right. So
The question is definition of high risk.
definition of high risk and how long can you store stem cells?
Well, second, easy, it's indefinitely.
And indefinite.
Indefinitely. The first
Provided
one
somebody keeps
is
pushing the dry ice in there, you're okay.
the first one is still discussed. We discussed that in the previous session. Currently, high risk is mostly high risk defined by cytogenetics. There is also the ISS, so there is a
Yes.
combination of ISS, International Staging System, based on albumin and beta-2 microglobulin, and cytogenetics. And for cytogenetic abnormality, currently it's translocation 414, deletion 17p, and translocation 1416 mostly. But now, as we discuss, we are thinking of introducing 1q amplification as a marker of high-risk disease. But currently, it is 3-1, translocation 414, deletion 17p, and translocation 416, which are in all current publication.
Right, right. But as we've also discussed, we're still exploring what is the best way to manage or treat once we identify those. Okay? Yes, all right.
So maybe go on
So
myeloma.org.
how far down do we need to go here?
So you mean what kind of high-risk features? Yeah, some
Right.
oncologists will never know them, So you just go on myeloma.org and they have, information there, and they can tell you what high risk is. Because you just have to it's hard to remember, part of chromosome 4 jump on chromosome 16, that's bad. If you lose part of chromosome 17, the long arm, that's bad. So those are the things that, people don't remember them, but you need to see them, written
Right.
somewhere. And I think myeloma.org, you have that, don't
Oh,
you?
yes.
Yeah.
And it was on that one slide that I put back up. But frankly, the really simple way to identify high risk is if the myeloma relapses in less than a year.
Absolutely.
That's basically
I
it.
wanted to
That's basically the
say
bottom
something
line.
about that. What we say is only numbers, percentages. But for a given patient, the prognostic value of a given translocation of a given cytogenetic abnormalities, we don't know. And I would give you the example of translocation 414. We now know that if you have only translocation 414, it's not that bad. With new treatment, it's possible to achieve a high proportion of MRD negativity with translocation 414 alone. If you have what we call a double hit, two cytogenetic abnormality associated with worse prognosis, then it's become more difficult. But translocation 414, in my opinion, you can never say.
Right.
So I guess, what does high risk mean to you? When we say you have high risk myeloma, do you know what that means?
My assumption is that your lifespan could be shorter than most.
That's it. That's it. It's two things. The response duration is shorter than the standard risk patient, and the survival is shorter. High risk for poor outcome. All right? So what define high risk is those chromosome abnormalities that we don't understand why sometimes they cause these poorer outcome. It's just the cells are more resistant to treatment, the immune system may not working well, who knows? And that's why a lot of centers now trying to look at the genetic of myeloma cell itself and the neighborhood where they work to try to find those factors that make this myeloma relapse quickly and have a shorter survival. Because if you find those markers, then you start attacking them. You not just shoot from the gun with high-dose melphalan. You can be smarter, and that's the goal, I think.
Right, right. But the final point I would make is that as we travel around the world and we present to groups of patients in different countries, in China or in Turkey or wherever, patients will say, well, I don't have any of those features that you've mentioned, and myeloma relapsed after 6 months. So what is clear is that in different patient populations, myeloma is becoming less responsive and relapsing, but it's not identified by these traditional markers that we have. And so I think that the simplest definition is just based on how the myeloma is reacting. Do you have a good deep response? Is it sustained for 6 months or a year or not? And then based on that, make decisions. And it may be linked to some of these markers, but many times in other places, it's not linked to these things that we've identified. Okay, I think that there's a red light blinking here. Does that mean anything?
Are we done?
Yeah. Are we all set? All right, so thank you so much.